My name is Dr. Bram Ganesan. I'm a GP here in a surgery in Southampton. I've been a GP here for 5 years at this particular surgery. My particular list has a larger proportion of people of South Asian ethnicity than other lists in our locality in Southampton. I think that's predominantly because I've taken over from a GP of South Asian background. But there are two majority cohorts divided amongst socioeconomic background. The lower socioeconomic cohort, when referring to health aspects in the South Asian community, my experience is that they tend to live in higher, more densely populated households. There are some patterns within these families, but it is generalisation to say that alcohol in particular plays a part in the health aspects of male members of those households. Females tend to be quite high users of medical services, but in particular with regards to other family members as opposed to themselves. I am also aware that there is a bit of a reluctance for female members to approach me, especially younger female members, and I wonder if that's because of the difficulties that they might have, cultural difficulties they might have with approaching a male for female problems. Compared to the lower socioeconomic cohort, the more affluent cohort tend to be more involved with their health requirements. They seem to be more interested in seeking intervention for health problems as they develop earlier on, and are more involved with doing research and finding other sources of information apart from their GPs. I think that the health outcomes are not as good for this particular ethnic group, despite the affluence of the cohort compared to a more endogenous population within the UK, in my experience. The reasons I suspect that there is still a difference despite the level of affluence is because of the cultural differences within these communities, the difficulties perhaps that these cultures have in amalgamating fully with the culture in this part of the country. For example, with regards to diabetes, many of the dietary modifications that need to happen aren't easily providable with ethnic diets compared to the more local traditional food. I think that the two cohorts are large cohorts within this population. However, there are other cohorts, and in particular a minority but significant cohort of younger South Asian descendants who have adopted a very much cultural lifestyle similar to that seen within endogenous populations, who are similar in terms of their health outcomes and expectations as the more other populations that I look after. One of the more frequent encounters we have is with regards to diabetes in Asian populations. I think it's well known that diabetes is more prevalent in this population. Diabetes has a legacy effect, and starting early treatment is important. However, in males in particular of the low socioeconomic group, you do tend to find people less engaged, and therefore they have worse outcomes as you see them later on. They tend to be more complications as a result of their not engaging to start off with. And culture has a part to play in other sort of common ailments amongst this community, not just diabetes, but cardiovascular disease. It is affected, the outcomes are worse because the difficulties with the culture to change, to adopt a more endogenous culture, a reluctance to exercise and change diet. So there is a correlation.